Textbook of Rockwood and Green's Fractures in Adults. Section 1. General Principles. Biologic and Biophysical Technologies for the Enhancement of Fracture Repair. Introduction. Fracture repair includes multiple signaling pathways and regulated by both local and systemic factors. Complications may occur during fracture healing, such as delayed union or non-union, especially in morbid patients. Bush et al. Found that direct costs regarding tibial non-union reaching $7,500. To improve and expedite repair, surgeons may use bone grafts, biologic agents, or physical stimulation. Bone grafts and bone graft substitute. Indication of use include malunions, non-unions, arthrodesis, and reconstructive procedures. Factors that affect bone graft incorporation. First, osteoinductive growth factors. Second, osteoconductive extracellular matrix. Third, osteogenic pluripotent stem cells. Gold standard is autogenous bone grafting. However, morbidity such as donor site pain, nerve or arterial injury, infection, limited donor site, and increased operative time may occur. Alternative is allogenic graft. Properties of types of autologous bone grafts. Osteoinduction refers to the recruitment and differentiation of pluripotent mesenchymal stem cells into bone-forming osteoprogenitor cells, mediated by graft-derived growth factors such as bone morphogenetic protein or BMP. Osteoconduction involves the creation of the bone scaffold that supports the ingrowth of blood vessels and perivascular tissue as well as the attachment of osteoprogenitor cells. This occurs in an ordered sequence which is independent on the three-dimensional structure of the graft, the local blood supply, and the biomechanical forces exerted on the graft and surrounding tissues. Osteogenesis refers to the process of bone formation after terminal differentiation of osteogenic progenitor cells into mature osteoblasts. These three processes create the sinews, scaffolds, and cells necessary for an initial phase for fracture healing. Autologous bone. Autologous cancellous bone graft may be used for fractures that do not require immediate structural support. Advantage is its tremendous biologic activity. Autologous cortical bone graft provide good structural support but weaker osteoconductive and osteoinductive. It may be used in fractures that require immediate structural support. This is the picture of 52-year-old laborer developed a scapulinate advanced collapse and scapuate non-union, which are shown in plain photographs as well as on CT and MRI. He underwent a total wrist arthrodesis augmented with iliac crest bone grafting and demonstrated a good healing of the vision at 6 months. And this is a picture of a 22-year-old man with a scapuate non-union that has led to a humpback deformity seen in preoperative radiographs and CT. He was treated with internal fixation augmented with a vascularized medial femoral condyle graft. Radiographs immediately post-operatively and then every 3 months demonstrate gradual healing of the non-union with graft incorporation. A CT scan at 1 year post-operatively demonstrates a good healing of the union and graft incorporation. Complication that might happen when using bone graft is longer operative time for donor harvesting. Most common site iliac crest. Complication that might happen include infection, superficial and deep hematoma, sacroiliac injury, urethral injury, vascular injury, and iliac crest fractures. And in other sites like proximal and distal tibia, distal radius, greater trochanter, medial femoral condyle, the complication that might happen include post-operative pain and superficial hematoma. Allogenic bone. Limitations in allogenic bone include associated with its preparation and sterilization such as freeze-drying and freezing or irradiation. Graft incorporation may be impaired in grafts with poor vascularization. Acid extraction of allograft bone is demineralized bone matrix or DBM, which contains type 1 collagen, non-collagenous proteins, osteoinductive growth factors BMPs, and TGF-betas. more institutive potential than allograft. These are the bone graft substitutes. First, calcium phosphate ceramics, hydroxyapatite, 3-calcium phosphate, calcium phosphate cement, and calcium sulfate. Calcium-based bone graft substitutes and calcium phosphate-based cements. Calcium-based bone graft substitutes are best used as bone void fillers, may be used in skeleton as parts where tensile strengths are low or non-existent. Calcium sulfate, which is much more rapidly resorbed than the other calcium-based materials, must be used in parts of the skeleton where compressive strain is required for only short periods. Enhancements of fracture healing with biologic therapies. Enhancement of fracture healing with biologic therapies consists of mesenchymal stem cells and progenitor cells, bone morphogenic proteins, WNT proteins, other peptide signaling molecules such as TGF-beta, PGF, FGF, and PDGF, prostaglandin modulators, and NSAID. Bone morphogenetic proteins or BMP. BMP7 is recommended in recalcitrant non-unions of long bones. BMP2 is recommended in treatment of open tibia fractures and fractures in large cortical defects. Other molecules may be used such as NSAID, where NSAID are safe to be used as analgesics in short durations, 10 to 14 days after fractures or spinal fusions. Bone morphogenetic properties. In this picture, it is shown that sequential radiographs of a tibial non-union treated with a recombinant human OP1 immediately postoperatively and at a 9-month and 24 months after intramedullary nailing. Note the bridging callus and subsequent tibial union. This picture shows that radiographs of a patient who had sustained an open fracture of the left tibia Gustilo-Anderson type 3B and was treated with an unreal intramedullary nail and 1.5 mg per milliliter recombinant human BMP2. The fracture was considered to be clinically healed by 20 weeks and healed radiographically by 26 weeks. Systemic enhancements of fracture healings consist of parathyroid hormone, growth hormone and insulin-like growth factor, statins, bisphosphonates, and osteoclast inhibitors. Parathyroid hormones. Parathyroid hormone induces fracture healing via modulations of the WNT pathway. Total callus formation and chondrogenesis induction were increased in fractures in rats, which were treated with daily injection of PTH. Radiographs examining callus formation in the femurs of rats 2 and 3 weeks after injury. Safranin O staining of fracture slices 5 and 10 days after injury. Chondrogenic cells are stained red in C, D, E, and F picture. Micro-CT analysis of callus and bone volume in mineral density. Physical enhancement of skeletal repair. Mechanical and biophysical stimulation. Sarmiento et al. Found that early white pairing accelerates the fracture healing process. Degree of stability also has a direct impact on repair process. Distraction osteogenesis divided into 3 phases: latency, distraction, and consolidation. Another physical enhancements of skeletal repair consists of electrical stimulation, ultrasound stimulation, and extracorporeal shock wave therapy. Distraction osteogenesis for the treatment of non-unions is appropriate. However, there is an established risk of fractures after removal of external fixators. Electrical stimulations may be used in non-unions and delayed unions. Ultrasound stimulation can be used for treatment of fresh closed fractures of the distal radius and tibia treated in cast or external fixation device. This picture showed sequential radiographs of a patient who sustained a grade 2 distal tibia fracture that underwent irrigation and debridement with placement of an external fixators. At 4 months, the external fixators were removed and the patient was believed to have a delayed union. Daily treatments with exogenous ultrasound stimulation was started. At 1 month of treatment, the patient progressed to partial white pairing. At 2 months, radiographs showed continued progression of healing, and at 6 months, the patient was pairing with full white without any pain. Thank you.